I am heading back to the hospital for the first time since I was discharged 18 months ago. The last time I was dropped off at this location, I didn't leave for 28 days.
Ben is my younger brother. He's the youngest in the family. He's a go big or go home, and he often usually hits the go big mark right on target.
I tend to not do anything halfway. It started with I needed a way to get healthy, so I started running triathlons. I've done the Minnetonka Sprint Triathlon. Why can't I go straight to Ironman? So that's what I did. In 2017, I signed up and did Ironman Wisconsin.
He set this goal, he did it, and he made it. I'm so proud of him. He had actually been at Mayo Clinic for an executive health physical in February.
2 days of getting poked and prodded to make sure I was ready for another Ironman. 5 days later, I get on a plane where I contract COVID-19.
We were just starting to hear about COVID.
I had 102 fever, decided let's give the hospital a call. My wife dropped me off at the front door. First, they checked my oxygen levels, and it was 75%. 1 liter of oxygen, then 3 liters of oxygen, then 6 liters of oxygen.
And I talked to him one last time around 9 p.m. He says, I'm on 15 liters to maintain at 90%. And if I go to move, I fall to 70%. So I got off the phone and I told my husband, he's intubated by the morning. But then that next morning, I got the phone call from Deanna, and she just said, I just got off the phone with the doctor, and I think I okayed them to do ECMO because they said if we don't put him on ECMO, he's going to die. My whole world just kind of dropped away. Like, what's happening?
When we were notified that we had our first COVID patient that was going to need ECMO, it frankly scared me to death. Ben was the first patient in the state of Minnesota to require critical care for COVID, and he was also the first patient to require ECMO.
They had authorized one visitor, and so I'd go in and see him, and first thing I would do is I would release one of his hands. He doesn't remember this, but I distinctly remember saying, hey, it's your sister, I'm here.
Go away.
And I was like, I love you, and he signed, I love you back to me. Got there the next day, and he was completely unresponsive, and that was a hard day. I cried that whole entire day. And that was the day the palliative care team saying, we recommend that you take pictures because in the event he does not come home, you're going to need to show his family why he couldn't come home.
All I remember are the hallucinations. I had very terrible hallucinations throughout the entire first 7 days when I was under sedation. St. Patrick's Day, I woke up. And then it was the slow, steady climb of getting better. On Friday, the 20th, I stood for the first time while on ECMO. 2 days after I stood, they removed the ECMO cannula. 3 days after that, they removed my intubation tube. And by the time I left the hospital, all I had left was supplemental oxygen only when I was walking or moving around. I didn't need it to just sit. I get out of the hospital on April 6th, get to hug my daughter, hug my wife. I had my first walk the day after I was released from the hospital, and it was 7 minutes at 1 mile an hour on the treadmill. So excited. I was so proud of myself.
He had then decided he's going to do a race. He's like, Mike Riley called me. And I was like, are you kidding me? Like, the voice of Iron Man called you? He was like, yeah. And he was like, what do you think, Ben? Should you get back out on the race course? And I thought, well, yeah, why wouldn't I get back out on the race course?
The Ironman wasn't the goal. The Ironman was something out there to force me, to motivate me to get out every day, to walk the 9 minutes, then 10 minutes, or the days that I just didn't want to get out of bed or had trouble getting up the steps. I competed in Ironman Tulsa. The fact that 14 months to the day previous, I had my ECMO cannula removed, I couldn't believe I was there.
He saw him turn the corner, And then Mike Riley goes, and here he is, Ironman finisher, COVID survivor, Ben O'Donnell.
Until I crossed the finish line, I didn't know if it was going to really happen. The euphoria, but then also just all of the emotions of the last year hitting me. It happened all at once.
This is a great opportunity for me to be able to give something back to them. I've had the time to reflect about the impact that you all had on my life. The fact that I'm here, the fact that I was able to get home to my daughter. I couldn't have done any of this without all of you. And to thank you for that, I have my finisher's medal from that day. That this is the medal that my sister put around my neck as I crossed the finish line. One.
Thankfully, I was able to be put on ECMO, and now thousands of people have been put on ECMO and have survived COVID. And I feel fortunate to be the first survivor in North America with COVID on an ECMO machine. The fact that my story and my treatments were able to help others to survive this virus is, I think, I have no prouder moment than that.
I really love that story. It's a really good one. And sitting here, I'm just feel very humbled around having all of you healthcare providers here with us today, and just thinking about how many of those stories that you've helped create that we'll just never be able to count. Thank you to those of you joining us in person today, and thank you to those of you joining us online. It's a real pleasure to be here for the Medtronic Lunch Symposium today. Thank you to the EPIC staffing team for inviting us here and for your partnership. We're really grateful for the opportunity to be able to share the story today. I am thrilled to be able to introduce our speaker today, Nitasha Joyner. Nitasha Joyner joined Medtronic as our senior medical education and training program manager for all of cardiac surgery. She's a certified clinical perfusionist. Before joining Medtronic, Nitasha spent her first 17 years of her career with the University of Minnesota Medical Center as a perfusionist, as an ECMO coordinator, before she became the chief perfusionist there. Natasha's passions include pediatric perfusion, mechanical circulatory support, and ECMO coupled with training and education. And her experience and passion just give her such a unique and fantastic perspective that I'm really excited to see how it's going to come to life in the conversation that we have today and her talk today. So please join me in welcoming Nitasha to the podium.
Thank you, Neil. Thank you so much. It's a pleasure to be here with each one of you today. And that Ben O'Donnell story is very close to my heart, as he was our first ECMO patient and survivor of COVID-19 in North America. And I did have the pleasure of being chief perfusionist at the university throughout that process. So today I'm going to talk about something that I think as clinicians, it's really important for us to think about. Cleared for ECMO. Does it matter? As a perfusionist for 17 years, lots of stuff that I've used for ECMO patients has been off-label. We haven't had products that have been approved for ECMO. So does it matter that there's products approved for ECMO? And as clinicians and as patients, should we care? I am a Medtronic employee, so that is my disclosure, and I have been a perfusionist for 17 years. As we talk about some of the FDA stuff, I'm not going to lie, I'm not an expert, so I do apologize for that, but I'm just going to share the knowledge that I have with all of you. I do want this to be interactive, so those of you online, as well as everyone in the room, if you don't mind taking out your phones and either scanning the QR code or going to slido.com, and you can enter that 1494457. It'll just make it more interactive and fun for all of us as we're here. We're not recording any of your results or data. We're not collecting any of it. It'll just be an interactive session for all of us today. I'll give you all a few minutes to do that, and then we'll... Looks like it's working for most of you. It will still be here on in the corner. So anyone that hasn't scanned in yet, you can still scan the QR code, and we're going to see some live updates as people start to input their results. Looks like we have about 60 respondents so far. Thank you for all of you that have responded. We'll keep collecting those respondents. It's awesome. We're starting to see, we have some nurses, some people from industry, as well as some ECMO specialists all joining us today. So the first question that I have for everyone is, in your opinion, a product that's approved or cleared for ECMO, does that matter? No, it doesn't really matter. I've used products off-label for ECMO my whole career, and they've worked just fine. Or do you maybe try to use products on label? You'd really like to use only products that are on label. You didn't even know that there were products that were approved for ECMO and that there was an ECMO indication now. Or maybe you're not sure. Maybe today you're here to learn more about what that cleared process means and what the testing for those products are. Awesome. It looks like we have over 90 respondents so far. And so about 54% of the respondents, 56, are saying that it doesn't really matter, that we have all these products off label and they've worked just fine. There's another about 25% or so that try to use on-label products. And we'll kind of look at this again at the end. Today, I'm going to kind of go through what is that device regulation? What does it mean to be on label? What is that testing and design? What does that look like? Why is it different from a device that I bring to you for cardiopulmonary bypass? How is that different as a clinician? We'll look at some of the products that Medtronic has brought to market. And then finally, we're going to close it up with another patient impact story. The story of Ben is extremely impactful, and it's because of products that companies like Medtronic have made so that patients like Ben are able to be supported. So some of the difficult challenge conversation is, what does it mean? Where do we fall? This is something that as a clinician, I didn't really understand and didn't fully, when my Medtronic rep would talk to me about 510K approvals, it was something that I wasn't super familiar with or super comfortable with. So I'm not sure if any of you guys fall into that category, but just giving a real high level overview. So there's 3 different classes of medical devices, anything from class 1, which are the least amount of risk. So these devices might be holders, brackets, some of the adapters that we use might fall into that class 1 category. Then you have your class 2 category. Most of the items that you guys use for cardiopulmonary bypass, they're going to fall into that class 2 regulation. Class 2 regulations require 510K approvals for them, but they do not require any clinical research or data. They don't require big tests to bring products like your cardiopulmonary bypass oxygenators to the market. And then finally, those class 3 devices, such as pacemakers or valves, things like that, those are going to be the highest risk for your patients, and those require much more extensive testing. So what are some of those testings? The 510K, how that works is the submitter must compare their device to one or more similar devices that are already on the market, and they must show that they're substantially equivalent. So if I was to bring an oxygenator to market to you, I just have to show that it's equivalent to another oxygenator on the market. So for cardiopulmonary bypass, what does that mean? Those are all approved for less than 6 hours of use, right? So we're going to test those devices and make sure that they're going to work amazing for your patients for the purpose of cardiopulmonary bypass. Then when you look at the PMA or the pre-market approval, that's what the class 3 devices fall under. And so, sorry guys, the class 3 devices fall under that. They are the most highest risk, and so they do require scientific evidence, which is typically done in the form of clinical trials. So you might ask, why did we not have devices for ECMO previously? All of the ECMO devices before 2016 fell into this class 3. So big clinical trials were required. No one in industry is going to be able to provide that type of level of support to get those devices approved. We also have investigational device exemptions. That's how you're going to test your device. So if I brought a valve to market, you'll go into that IDE process to be able to use those devices to show that clinical evidence and data. I think we're all familiar with the emergency use authorization, especially with the COVID-19, where a lot of the products that were previously off-label were now be able to brought to market for on-label use. The one important thing as a clinician to note is at the end of this year, on November 7th of 2023, that emergency use authorization for all of the products that were approved for COVID-19 is going to be removed. So we'll no longer have that option. And then obviously the humanitarian device exemption. Those are devices that are small niche markets in which it's hard to find another device, or you can't find another device that is equivalent to that. And so I can think of some of the VADs that we tried in our pediatric population as a clinician that would have fallen into that humanitarian device exemption. So let's kind of look at where we were at. So with cardiopulmonary bypass, less than 6 hours. That means we're going to test all the devices and make sure that they're going to work in the purpose of cardiopulmonary device. Like we talked about, this is going to be things like your oxygenator, your tubing, connectors, pumps. And then you have your long-term or implantable devices, something that I talked about like a valve. So those are going to have much more clinical evidence and testing. Where would an ECMO oxygenator fall? What should happen? Originally, it was under that long-term implantable devices that would require clinical testing and data. So that wasn't really an option for industry to bring that to us as clinicians. So then we were using items that were approved for cardiopulmonary bypass off-label for ECMO. But if you ask me as a clinician, I really think these devices fall into their own separate category. Luckily, on February 12th of 2016, the FDA did change the regulation from a class 3 device down to a class 2 device and actually gave it its own indication. So it gave it an ECMO indication, which means that it's more than 6 hours or greater than 6 hours of use. Let's look at what that identification actually says. I know this is real small for those of you up here, but it does describe that this is for a patient that is on long-term respiratory or cardiopulmonary support greater than 6 hours. This device or accessories provide assistance for physiologic gas exchange if a patient with acute respiratory and acute cardiopulmonary failure. That's what's really important, is that these patients, all of our ECMO patients, it falls under that acute respiratory or acute cardiopulmonary failure with imminent death if we don't have a device for them. So this was in 2016, really changed how industry was able to bring products to market and how as clinicians we were able to think about products that previously we only had off-label indication. So I have another poll for you here, both online and in the room. Now that there is a path for the FDA for ECMO clinicians, as a clinician or a patient, should we care if our products are cleared for ECMO? So results are coming in. So we have about 70 results, getting close to 80 results again coming in. So about 71% say yes, as a clinician and as a patient, you should care whether or not your device is approved for ECMO or long-term indication. About 9% or so say no, and the rest are unsure. Hopefully, as we look through the process, it'll be even more clear for individuals what that means as a clinician. What does it mean when you have a product that comes to you? So when they developed this ECMO indication, it had very specific special controls that were required in order to bring products to market. And we're going to look at some of those so you guys better understand it today. Something I really didn't understand until I joined and started doing a little bit more research on this. So the first requirement under this new regulation was technology characteristics. What does technology characteristics mean? It means that the geometry and design is for the intended use. So I no longer can take an oxygenator that's intended to be used for cardiopulmonary bypass and just pop it in for ECMO. I need to think about, what does that mean? If we're going to have long-term use, if I have corners that are going to be static, or if I have a cannula that's going to move, that's important, right? The next piece is, once you determine those characteristics for the intended use, now we have to look at bench testing. So does it have mechanical integrity, durability, reliability? And again, this is for the intended use. When we bring you products for cardiopulmonary bypass, we're going to test those for the 6 hours and make sure that they're really reliant and provide the best possible options for you for that short term. For this long-term indication, the same thing happens, but we're going to test it for long-term, right? We're going to test it for 14 days, 30 days. We're going to look at that longer-term testing. Testing for biocompatibility. Again, they're going to look at the extended use biocompatibility. So all of these things are for what each of the clinicians are seeing for ECMO. So again, ECMO duration was averaging 7 to 14 days prior to COVID with cardiac or respiratory patients. Now they're getting a little bit longer. But so industry has to think about those things and look at things like biocompatibility and that extended biocompatibility for long-term use. The next piece that happened in this special control, the fourth piece, was the in vivo evaluation. This is what was very different than previously when it was a class 3 device that required a PMA. It now has its own way to do the testing and in vivo evaluation. Again, this is for the intended duration of time. So if I'm bringing you a product that says less than 6 hours, that means I've only tested that item for 6 hours. If we're bringing you a product for ECMO or the greater than 6 hour indication, it means that they did that advanced or extended testing, and we're going to look at some of that today. And then finally, the other pieces are the sterility and shelf life and labeling of the product so that it's appropriate for the intended use for your patients that are actually on ECMO. So I'm going to spend a little bit of time looking at what the design and process was like for a company like Medtronic to bring a product to market. So the first thing that they did was customer input. They started with a white sheet of paper and talked to a whole bunch of clinicians like yourself to learn what the process was, what did you like, what did you not like. Then they looked at risk. One thing that's really important in this development process is looking at prior complaints. Going in, they use the ELSO registry and other data to figure out what were the issues. Oxygenators clotting off, right? Cannulas migrating and moving. So in their design, they had to approach and look at that risk mitigation of those things. Then looking at the prototypes and bringing all those voice of customer and risk assessment together into what should the device look like? What do the clinicians need for the device? And what's going to provide the best for our patients? From there, then they'll test those devices in cadaver labs or animal labs, or even just on the bench to make sure that the concept works and which of the concepts works best, right? More fibers, less fiber, longer flow path, less flow path, different security devices, and see which one is actually the best for your patient. Then they do the verification testing, and finally the process validation. So, right, your process validation, making sure everything in the process lines up so that you can submit it to the FDA for this. I'm going to go through just a couple of products that Medtronic has brought to market and what the process was for those. So the first one we'll look at is the oxygenators. Again, this is more about the design and why the testing that they did is important and why as a clinician we should care. Why should we care that it's a different product than others that are on the market? So again, they looked at the geometry and design, the transverse flow path after looking at all the different flow paths for different oxygenators was the most efficient and effective for that longer term use. However, corners and areas of stasis are a big problem and challenge. So looking at things like a circular flow path, right? All of our blood vessels are circular. And so a circular flow path gets rid of that area of corners. Developing things that actually create a smooth transition and no areas of low flow or stasis, because again, looking at some of that clot formation and long-term use for the device. This is probably my favorite thing that I had no idea when I joined Medtronic that had been done. All of the oxygenators were primed for 30 days before they did any of the testing. So when they were looking at that risk mitigation, they know that as clinicians, we have ECMO circuits sitting in pump rooms and in closets, right? We prime those and have them ready for our patients. Previously, nobody was priming their circuits and testing them. If you look at your cardiopulmonary bypass oxygenator, the IFU specifically tells you that you're supposed to use it immediately after priming. You're not supposed to prime it and let it sit, right? Because they haven't tested for that. In this, they 30-day pre-primed storage with this phosphate buffered solution before any of the bench testings to validate that all the gas transfer and everything is still efficient after this. I'm going to go through some of the bench testing. The details for me are not what is important for you guys to understand. The importance is just the amount of testing that went into it and what that testing kind of looked like. So again, a 14-day pressure drop after these devices were primed for 30 days with other comparisons of other devices that are on the market off-label. And so they were able to prove that the pressure drop over 14 days stayed consistent. As well as oxygen transfer, right? So over 14 days, ran these, did oxygen transfer, as well as carbon dioxide transfer rates. So again, looking at all of these features of the oxygenator to make sure that the longer term indication that the device is going to provide that for you, your patients. Looking at hemolysis testing to make sure that you don't have increased levels of hemolysis with this longer term use, which is, as clinicians, we know that that becomes a problem, right? The longer you use the devices, the more hemolysis. What about platelet retention, right? The longer these devices are in, the more your platelets are consumed. So they also tested for platelet retention on the device. And then finally, after they were able to validate the device and were able to do all these bench testings to prove that it performed the way that they intended it to perform, then the in vivo studies for the animal study, a 96-hour animal study on the device. I'm going to move on and talk about some of the catheters that were brought to market. Again, the Crescent that Ben O'Donnell was on, and how valuable in the testing and long-term indications for that are, and what those look like. How are they a little bit different, but also very similar? The materials for long-term use. So finding materials like Elastion. I think all of you now are familiar with Elastion. It's biocompatibility and thromboresistant. And so it's used in implantable devices. While it's more expensive, it does provide that longer term biocompatibility and thromboresistance that we're looking for. Things like radio opaque markers so that it's easier for people to identify placement and movement of cannulas, which is again a risk mitigation, right? As clinicians, we know these are challenges that we experience every day. Moving on to some things like durability testing. And again, this isn't exhaustive of all the testing was, but just giving you a general overview of what some of the testing looked like. So durability testing, make sure that that securement device doesn't move, right? If these cannulas are migrating or moving, or if they're cracking, that's not gonna be good for our patients. And so making sure that they really can withstand the test of time for each of your ECMO patients. Cannulas also went to lab testing, so testing these for 30-day long-term use for hemolysis, also testing them on the bench, flowing through them for 30 days, making sure that the biocompatibility testing is under this 30 days. Again, when we bring products to market for you for cardiopulmonary bypass, we're testing all of these, but we're testing them for that 6 hours or less than 6 hours of use, right? These we're testing for long-term use and making sure that if we bring you a product to market, it's going to be reliable for that long-term use and long-term indication. And finally, the in vivo studies. These were 168-hour studies over a 7-day period looking at, thrombus and hemodynamics and injury to anatomy and hemolysis, mechanical device failure. So making sure that these work in the fashion that they're intended for that longer term use for your patients. So products to market, in 2016, the FDA created this pathway for products to come to market. And here are some of the products and clearances testing that was done by MC3 and Medtronic to bring products like the Crescent dual lumen cannula or the Crescent RA for pediatrics, the Nautilus and Nautilus Smart Oxygenator, as well as the Biomedicus life support cannulas that are coming to market now for Medtronic. Well, it was a long process and there was a lot of testing and a lot of design considerations that went into it. We now have a portfolio of products that are approved for long-term use and ECMO indication. And as the EUA leaves in November, does it matter now that you've seen that testing? Now that you know what it's like for a less than 6 hour device and a greater than 6 hour device? As a clinician, does it matter? Is this something we should care about? Is this something we should think about when we're putting patients on ECMO? And should we keep pushing industry to do better, to be better, and to do the testing that's required for these long-term indications now that there's a pathway? So either everybody is just making me feel really good, or the presentation did at least give you some more insight into, as industry, what it took to bring some of these products to market. I know as a clinician, there were times that I was like, you guys have been talking about this forever, right? Like, I feel like it's been a long process to get these things in our hands and to our patients. But there are products now that are approved. And so I think as clinicians, we can see here of the 80, some respondents, 86% think that it is important that as a clinician and as a patient, we should be looking at that ECMO indication. I appreciate the time today and talking about this, but really, why do we do this? It is for our patients. And I just thank each one of you that spends time to do best for your patients and take care of these patients. I know you're often away from your families and sacrificing a lot. So from Medtronic, we thank you, and from the patients. I'm going to close up with one more patient story of another patient that was impacted by these devices that have been cleared for ECMO, and the testing's been done.
After we had gotten engaged, we had decided to go on vacation. Over a couple days, I knew something wasn't right. It went from, me kind of walking around, not really having any issue, thinking I can make it through this, I'll be fine, to the next day having to go to the hospital, getting admitted. And as soon as I got into the room there to be admitted, it went from, I didn't even want to get up. I couldn't sit up. I didn't want to sit up. I didn't want to get up. And just got progressively worse, where I couldn't breathe.
Carlos was admitted with COVID-19. Not only were his lungs failing to the point where he couldn't oxygenate his blood and couldn't remove the CO2, but he also had these big pneumothorax, big tears in his lungs that caused air to leak out outside of his lungs and kind of throughout his chest. All of that air can compress on the blood vessels in the chest, and that can cause your heart to stop, and that can cause a patient to die almost immediately, if not recognized and intervened upon quickly.
When I was in a higher treatment ICU is when my oxygen was at its max. My lungs were so damaged that they weren't processing the oxygen that was needed for my body.
This is one of those cases when you have a case like Carlos's, where you're failing in your ability to keep his oxygen and his vital signs where they need to. So that's why we progressed very rapidly to being able to support him with ECMO. ECMO, or extracorporeal membrane oxygenation, is the type of life support that is used for patients in severe cardiac or respiratory failure. So usually these are patients who all other forms of life support have been exhausted.
You could tell that it was starting to at least give him some relief in the healing process. When I walked in there, the first thing he wants to do is smile at me, and he can't even smile. But you can tell that he's trying to smile. And I'm like, it's okay, you don't need to, it's okay. But it was just, again, the nature of his, personality and character.
I could move my fingers.
He could move his fingers.
Yeah. I felt myself getting better slowly. And now I know it was a lifesaver. I do. I know it saved my life. One day, my nurse comes in and he tells me, hey, Carlos, your wife told me your story and how y'all were supposed to get married on the day you got into the hospital. And he's like, I have an idea. He said, why don't we get married? Why don't you get married here? I'm on ECMO, I can barely move or speak, and I'm like, oh, you need to ask Grace, because it's up to her, it's her day.
I'm like, well, yeah, if he's okay, I would love to, because one of the things that I tell Carlos even now, it's like, I just wanted to have the honor of saying that I was Mrs. Swing.
It just shows how important treating every single patient that we have like a person first. That's essential for anyone to really heal.
Right after the wedding, I started to feel a lot better. And I just had that sense of purpose, knowing that she is there for me by my side as my fiance and now as my wife. And I knew I had to just be there for her no matter what, I wasn't going to give up. I look forward to so many more years and growing old together with her. I love her.
Again, thank you guys so much for the time and the care that you take for the patients. Both of those stories get me choked up every time. And I know each one of you has similar stories and situations in which have had an impact. And I'm happy to take any questions if people have questions.